Cardiac autonomic derangement together with altered ventricular repolarization paved the way to postoperative atrial fibrillation.
Dear Chairman, dear audience, with this presentation, I would like to touch the other part of the story called atrial fibrillation, and hope that despite being a little bit elaborate on the theoretical framework, you will be able to take one statement, take-home message. And why is it not working? That was our study is actually the response to the communication to the appeal of Professor Damiano group, and we all know that the perioperative atrial fibrillation is a very complex disease, very frequent, and still, despite not very high morbidity, it is significant, and we would like to all to get rid of it. So we would like just to tailor the therapies to those that they need, and not possibly gaining any false results or even unnecessary resource measures. So how we started to define the principle or to define the study question, we would like to see whether on the level of ECG, are there any existent parameters that could help us identify atrial fibrillation. We have some markers, highly significant for that, on the level of pave, and also we had some experience in defining the excessive autonomic modulation that's going to change after the operation, promoting the arrhythmia, as well as the QT variability that identifies uncoupling or the error QT interval that can be a proponent of atrial fibrillation. To keep it simple, it's easy to define the height of the wave, but on the other side it's very complex, so there exists some complex mathematical principles which I'm not going into brief detail, but just briefly, ECG can be described by a complex mathematical framework that has been applied. Actually, it was proposed 10 years ago here in Boston, published in Science and Nature at MIT, and we incorporated that knowledge into our machines and tried to ask ourselves, what, if at all, do we see on that level? Again, linear, non-linear, multifractality, non-multifractality, we wouldn't go into detail, but the bottom line is, now we have a 20-minute ECG recorded preoperatively, and just 2 points where we control the automatic process. So pretty much from there, we define some basic mechanisms also being explained by Hogg 10 years ago, but now upgraded in respect to the levels of sympathetic and parasympathetic modulation in those patients. So describing now the atrial fibrillation group and distinguishing it from non-atrial fibrillation group, we could identify as a critical or actually conventional marker the age, and also the arterial hypertension on borderline level. And from postoperative, we could see that the respiratory support is also a significant predictor of postoperative atrial fibrillation. But of note, it didn't influence actually the preoperative ECG measurements. So let's see what happens on the level of preoperative ECG, high resolution again. We see the differential values of QT interval. We see the PNN 50, that is significant. This is predictor of excessive vagal modulation. And on the top of that, we see the alpha 2. Alpha 2 is actually surrogate of a combined sympathetic parasympathetic activity on nonlinear level. That is telling us more than previous alpha 1 only on isolated cabbage groups. So for the first time, we are demonstrating now a significant correlation, which was then applied into further models. So what are the main findings, actually? PNN50 in our mixed group of patients with a concomitant ischemic coronary disease and aortic valve disease, and then the reasons is doubled in AF group. And AF group presented also with longer QT intervals. Also, quite in sharp contrast with our previous studies in isolated cabbage, we have now additional predictor of alpha-2 that can be incorporated into the model. Are we any further? Let's see. Yes, we are quite further than like 6 years ago, but still we are not there. So our performance now at the point of a good model with the area under the curve of 0.71. And in order to get back to you with the efficient model, we would like to have the values of around 95, so in the excellency level. So what we're now doing, we are now identifying additional markers on the preoperative levels. That means regarding the VIP, the substance P characteristic of a sympathetic system. And also, I would like to point that the ECG that is recorded before could also know or tell us something more on the actual occurrence of atrial fibrillation. So we are doing also that to incorporate in the model. So to conclude, we are describing a novel mechanism as opposed to isolated ischemic disease group that is characteristic with the excessive vagal modulation, and for the first time also QT elongation prolongation, and hopefully reaching higher patient numbers and incorporating multifractality, will be able to report better results that can be applied to identify subgroup patients that we then plan to take to the preventive measures. Thank you.
Thank you very much, Yuri. I have difficult questions. Are there any questions from the floor? Dr. Damiano.
Excellent, excellent study in a real difficult area. It's interesting that, you know, over the last 30 years, AFib, the incidence really has not changed. It remains the most common complication after cardiac surgery, and research like yours, I think, is sorely needed, and we really haven't made much progress, certainly with drug therapy in terms of prophylaxis. When you look at just the studies with the incidence, and your incidence of 37% is pretty consistent with, unfortunately, everyone else's experience. What is your long-term goal with this? Do you think you're going to be able to identify, if you identified a very high-risk subgroup, what would be your strategy to try to prevent atrial fibrillation?
Thank you for the excellent, inspiring question actually, not excellent. Our final goal would be to present you a model that could, on the level of 2-digit number, say you what's the probability of developing postoperative atrial fibrillation based on conventional as well as the pathoanatomical electrophysiological factors. That's the first part of the question. And by doing that, we could identify that subgroup that could go into the arm of potentially to receive any randomized delivery of some drugs and also some additional interventions. And if I'm a little bit more provocative, we could then maybe go a little bit forward to do some preventive prophylaxis. So active, wouldn't say nothing more, but could be also surgical prophylaxis.
Yeah, I think that's a great idea. You know, certainly in our animal models of postoperative AFib, inflammation seems to be the big mediator. So I like the idea of adding some CRP and other inflammatory mediators. And my own bias long-term is that modulating the inflammatory response after surgery may go further at preventing AFib than giving antiarrhythmic drugs. And that might be the strategy that will finally start lowering the incidence, because, you know, it's difficult. It's interesting, your findings on QT interval, because most of the, and that the longer one predicted postoperative AFib, but most of our drugs prolong QT interval also. So it's an interesting area, and good luck.
Thank you.
Dr. Mian, if I can maybe add a comment on what you were just mentioning about the QT. It's very interesting what Yuri was showing, because I was recently getting deeper into the issue of genetics in AF, and I was actually surprised to learn that people studying genetics are demonstrating that long QT syndromes may actually be a substrate triggering AF, or more likely to happen. So I think that maybe you would agree, these kind of studies are helping in shedding more light when selecting patients, because we are really just looking at very few bare parameters.
Thank you, Gianluigi. I would maybe just quickly comment on that. Maybe 10 years ago, when I was reading the literature, I would be considered a jerk, I mean, to tell that the QT could have some effect on atrial fibrillation and everything. And also followed by the studies from Lombardi and Pagani, Walder, La Rovere. But now, after 10 years, only last year, we found that beautiful, I think it's Danish study on 300,000 patients, or actually general population, finding that at the very tip of the either side of the parabol, there is an increased risk of then atrial fibrillation. We found that very, very, I mean, strange, and we couldn't explain it. And still, we're not able to explain it, but hopefully we'll understand it sometime.
Okay.
So Dr. Margarian from Massa, Italy. Excellent presentation, actually. And my first question is, how much is reproducible, your model? I mean, in clinical conditions, complex models doesn't function. You showed very high-level machine learning algorithms.
Yeah, thank you. So 5 years ago, that was a kind of, and actually I was assigned as a space astronaut, because it really looked like that. But now we have just a trolley with a laptop and with a NASA ECG, NASA developed ECG from Houston. And that's for Aspartas for the high resolution ECG. That's one thing. 20 minutes, any nurse can record that 20 minutes in a quiet surrounding, provided the room is warm enough. And then offline analysis, it's going to be controlled by 2 single steps on entrance, so that you verify, and the second, what has been done. And that's it. And then all the parameters automatically packed into the model, conventionally similar to STS or Euroscore analysis.
Which kind of mathematical model you use?
It was fast Fourier transform, and then we have the trend fluctuation analysis and the fractal dimension and Higuchi algorithm. But if you're not satisfied enough, I can provide you further context, because I'm not able to develop it myself. This is our colleagues from the institute.
Thank you very much.
Okay, guys, I'm really sorry. We have to move on to the next paper, because we are already out of time. But it's a really fantastic discussion.